morning. First of all, I would like to thank Pablo for his invitation to participate in this symposium. It's a pleasure to be in a face-to-face Congress again. I'm going to talk about our clinical experience with the ArtIOL lenses. Now that we have implanted more than 1,000 lenses, here you can see the main surgeons of this project, Pedro Tañá and José María Marín, working both in Optalvist in Spain. I know Pablo has explained the lens in detail, but I would like to give you some tricks about the folding and the insertion of the lens. I would recommend not to use viscoelastic material during the folding of the lens inside the cartridge. Instead, I usually use BSS, and I would also recommend not to fold the aptics over the optic really tight. Sorry, because it has music. I would recommend not to fold the aptics over the optic because they can stick together and it could be a little bit challenging to detach both aptics once the lens is inside the eye. I usually do a conventional cataract surgery through a 2.2 incision. I can implant the lens through that incision with no problems. One important thing is that you should make sure that the lens is properly implanted. So once it is inside the eye, you should be able to rotate it clockwise. So that's the way I make sure it's correctly implanted. Here you can see some technical specifications about the lens. There's nothing special to say about it because it's a standard hydrophobic C-loop lens. If you see the lens under the microscope, you won't see any rings or nothing special. It's a platform we are really used to implant. We're talking about ArtIOL lenses, but there are 4 different lenses. There's not just one lens. There are 4 different lenses with different amounts of negative spherical aberration. We can do different combination of these lenses depending on the patient expectations. So we can, as I've said, we can do many combinations to achieve the patient goals with the surgery. First of all, I would like to present the results in terms of safety and efficacy with the ArtIOL 25, as it's the largest group we have implanted. We have 355 eyes implanted with this model, and as you can see, the refractive results are good, with a post-op spherical equivalent of -0.18. with up to 90% of patients within half a diopter of residual refraction, with most of them within 0.25, and over 90% of patients perform 0 logmar in best-corrected distance visual acuity, as you can see here. There's not just a good lens in terms of refraction or visual acuity, it's also a good lens because it has, in my opinion, other clear benefits. Most patients are really satisfied and report their vision as quite natural, similar to the one they used to have before having cataracts. So this is something that makes sense if you think about the design of the lens and the things they have said before. We have a really small incidence of PCO. We think it's because of the shape of the posterior part of the optic, but this is something that it's hard to demonstrate. Because of these inverted meniscus, we have a really low internal reflection, so we don't have any halos reported and no other light side effects either. The anterior concavity of the lens removes all the external reflections, so we avoid that glassy appearance that most pseudophakic patients have, and most of them really dislike. Well, we're moving on now to the results of the rest of the models of the ArtIOL lenses. Here you can see the refractive results. As you can see, using the A constant suggested, we are having a slightly myopia in the post-op period. But interestingly, we are having really good results in uncorrected distance visual acuity. This is because this lens is really forgiving with that residual refraction defects after surgery. With all the distance corrected, we can see as the ArtIOL 70 performs really good results in intermediate vision up to 20/25 and near 20/30 for near. And as well, the results in ArtIOL 40 and 55 with intermediate level of negative spherical aberration is quite good in intermediate. If we compare ArtIOL lenses with the state of the art, we can see that ArtIOL 70 have better results in terms of intermediate and near visual acuity than one of the most popular EDOF lenses commercial at the moment. We have seen the graphics with all that distance corrected myopia, but if we see the lens working in the real life, we can see that monocularly ArtIOL 70 has really excellent results in intermediate vision with 0 logmar in intermediate and really good near vision as well with 20/25. ArtIOL 40 and 55 have similar curves, as you can see here, and surprisingly, ArtIOL 25, which is with the lowest amount of negative spherical aberration, also performs really good results in terms of intermediate and near visual acuity if we compare it with standard monofocal, as it's the gray line at the bottom of this graphic. So if you see the results we have just shown, we can imagine different combinations to achieve different results. I would suggest 2 different combinations we are using at the moment and with really good results. I think binocular implantation of ArtIOL 40 would provide our patients of an excellent distance and intermediate vision. And as you have seen before, they have really good uncorrected distance visual acuity as well. So they have really good tolerance to residual refractive errors. And the combination of ArtIOL 40 and 70 would provide good results in all distances binocularly without correction, without spectacles dependence. So here you can see that binocular results that I have said of the combination of the ArtIOL 70 and 70 and 40 with the yellow and orange line respectively. And as you can see binocularly, these patients have really excellent uncorrected distance, intermediate and near vision. As Pablo has said before, I think this is a good option almost for everyone, but I would suggest these implants in these particular groups of patients. All those highly demanding patients that want to have really good far and intermediate vision without light side effects like drivers or pilots, maybe young patients with unilateral cataract. The second eye in a monofocal lens implanted patient could also, in that way, we are improving the intermediate vision. And in particular, 2 groups of patients would be really suitable for these implants, as they are patients with previous myopic refractive surgery with some additional positive spherical aberration. So we are compensating that excess of spherical aberration, and all those patients with glaucoma or maybe some kind of macular issues, because we are enhancing the peripheral vision. That might be a good point in some of them in the future. And we are not reducing the contrast sensitivity that it's also important in that group of patients. So in summary, I will say that we have one standard, apparently a standard IOL, and we don't need to change anything in our standard procedure. We have really excellent refractive accuracy and visual acuity, as you have seen. We have different combinations we can choose depending on what we have on the table. So we are choosing different lenses, but the same platform. Most patients say they have really natural vision, which I think it could be one of the goals we have when we are going under a surgery, and we are improving peripheral optics, so that might have a role in patients' comfort. Thank you very much.